Welcome to this explainer. Today, we're basically putting on our clinical detective hats. If you've ever stared at a patient's symptoms and thought, how do I connect these clues to the actual forensic lab findings? Well, you are absolutely in the right place. Fungal pathogens, they can be incredibly tricky. We're talking everything from minor, kind of annoying cosmetic issues, all the way to life-threatening deep tissue invaders. But once you know the rules of the game, and specifically the diagnostic fingerprints these organisms leave behind, you can crack pretty much any case. We're going to build the ultimate study guide right here, giving you the clinical signs and diagnostic findings you absolutely need to master mycology. So, here's our game plan for today. 1. Primary versus opportunistic pathogens. 2. Superficial and cutaneous mycoses. 3. Subcutaneous fungal diagnostic clues. 4. Primary systemic fungal pathogens. And finally, number 5, opportunistic systemic fungal infections.
All right, kicking things off with Section 1, primary versus opportunistic pathogens.
Okay, let's dive right into this. The entire clinical playbook for mycology really hinges on one critical factor: the immune status of your patient. First up, we have primary pathogens. These are the heavy hitters. They are robust enough to set up shop and establish an infection even in a completely immunologically healthy host. On the flip side, opportunistic pathogens are, well, opportunists in the truest sense of the word. They absolutely require a compromised host defense to cause disease. We're talking about patients undergoing cancer therapy, folks with AIDS, organ transplant recipients, or even people who've just been on prolonged antibiotics. So the absolute key takeaway here: whenever you're faced with a fungal diagnostic mystery, your very first question should always be, what is the immune status of my patient? That immediately, and I mean immediately, narrows down your suspect list.
Moving right along to Section 2, superficial and cutaneous mycoses. Imagine you scrape the active border of a scaly skin lesion, treat it with 10 to 15% potassium hydroxide, a standard KOH amount, and look under the microscope. You might just see this classic spaghetti and meatballs appearance. This is the absolute hallmark of tinea versicolor, which is caused by the Malassezia genus. You'll see these numerous, short, stubby hyphae intermixed with clusters of round spores. It literally looks like a tiny plate of pasta. Clinically, what you'll see are hypopigmented or hyperpigmented macules, usually hanging out on the upper trunk or shoulders. And here's a pro tip straight from the lab. Keep an eye out for Zerli's sign, also known as the evoked scale sign. If you stretch or scrape the skin, these fine, briny scales just suddenly become apparent. Okay, let's put your diagnostic skills to the test. Tinea nigra is a rare, superficial mycosis caused by the fungus Hordia wernickeyi. It shows up as this brownish to black, totally asymptomatic macule, usually on the palms of the hands or the soles of the feet. Now, because of that dark, kind of scary appearance, what highly dangerous condition is it frequently misdiagnosed as? The answer is acral lentiginous melanoma. Crazy, right? Misdiagnosing this harmless fungal infection as a deadly skin cancer can lead to completely unnecessary invasive surgical procedures. The major clinical clue here is that tinea nigra looks remarkably like a silver nitrate-like stain. And if you simply do a KOH mount, you'll see these brown pigmented septate hyphae. Boom, that confirms it's just a fungus, and you've just saved the patient from a totally unnecessary surgical biopsy. When we're talking about diagnosing infections of the hair shaft, which are known as piedra, it really all comes down to texture and location. That gives you the answer instantly. Black piedra gives you these small, firm, gritty, dark nodules that are firmly adherent to scalp hair. They're stuck on there. White piedra, on the other hand, produces soft, kind of friable beige nodules that are just loosely attached, and you'll typically find those on facial, axillary, or pubic hair. Knowing that texture and location difference, it's a real game changer for instant diagnosis. All right, going a bit deeper into Section 3, subcutaneous fungal diagnostic clues.
Because these pathogens need to get past the skin barrier, they're typically introduced via some sort of traumatic inoculation. Think a puncture wound from a rose thorn or exposure to contaminated soil. Here are your clinical fingerprints. If you see a chronic infection with draining sinus tracts that are extruding these grossly visible pigmented grains or granules, you're looking at mycema. Now, if a patient gets a traumatic scratch and the infection starts to track upward, spreading right along those cutaneous lymphatic channels, well, that's classic sporotrichosis, caused by Sporothrix schenckii. Finally, phaeohyphomycosis. This is a group of infections where the fungi actually deposit melanin right into their own cell walls, giving them this very distinct brown to black pigmentation inside the infected tissues. I really want to highlight another massive, highly testable histological marker. When you take a tissue biopsy of a patient with verrucoid or wart-like lesions on their lower extremities, and you see these thick-walled cells with perpendicular septations that look exactly like copper pennies, you have definitively diagnosed chromoblastomycosis. These are called muriform cells, and they are an absolute dead giveaway. If you see the pennies, you know the diagnosis.
Moving on to the heavy hitters. Section 4, primary systemic fungal pathogens.
So, to survive deep within the warm, core environment of the human body, many of these primary pathogens rely on this incredible survival mechanism called dimorphism. Basically, this means the fungus exists as a mold, a hyphal form out in the cold environment. But once it's inhaled into warm human tissue, it shapeshifts. It converts into a parasitic yeast-like form, or in some cases, these large spirules. The classic memory hook? Mold in the cold, yeast in the warm beast. So who are the main characters here, and what are their microscopic clues? First up, histoplasmosis, caused by Histoplasma capsulatum. This one is an absolute master of hiding. If you look at a tissue sample, you'll actually find the fungus growing intracellularly, directly inside the host's own macrophages. Blastomycosis converts to a parasitic yeast in the lungs and is a classic cause of chronic pneumonia that can actually disseminate to the skin and bones. And then coccidioidomycosis is super unique because the inhaled spores don't turn into your typical yeast. They convert into these massive structures called spherules right inside the lungs. And keep in mind, these primary systemic infections often have very, very specific geographic ranges in the environment, so patient travel history is huge here.
And wrapping up our categories with Section 5, opportunistic systemic fungal infections.
Let's connect these opportunistic fungi directly to the compromised states that allow them to just flourish. Candidiasis is the most common one. You'll often see visceral involvement in patients who've had prolonged antibiotic use or have vascular catheters. Cryptococcosis is a major, extremely life-threatening cause of meningitis, particularly in patients with AIDS. Aspergillosis loves to invade the lungs and sinuses. And what's really terrifying about it is its strong propensity for actually invading blood vessels. And lastly, zygomycosis, or mucormycosis. This one is deeply tied to a very specific patient profile. It causes this rapid, life-threatening rhinocerebral syndrome almost exclusively in diabetic patients who are in a state of ketoacidosis.
All right, here is your ultimate takeaway study sheet pulled directly from the source material. This visual summary neatly categorizes the subcutaneous, systemic primary, and opportunistic mycoses we just covered, and it aligns them with their exact clinical presentations and risk factors. Whether it's matching those copper penny cells to chromoblastomycosis or linking meningitis in an AIDS patient to cryptococcosis, this matrix really just distills a massive, complex diagnostic landscape into a very clear, structured guide. I highly recommend pausing for a second and taking a mental snapshot of this. While we've covered the whole shebang today, from the spaghetti and meatballs of superficial skin infections, all the way down to those deep, dimorphic pathogens hiding in our lungs, but I want to leave you with this final provocative thought. Knowing the clinical signs, the scales, the nodules, the cellular shapes, that is literally only half the battle. How does knowing the patient's immune status instantly change your diagnostic playbook? The next time you look at a clinical case, don't just look at the lesion, look at the host. Because distinguishing between a primary pathogen that attacks the strong and an opportunistic pathogen that only preys on the weak, well, that is the master key to clinical mycology. Thanks so much for joining me on this explainer, and definitely keep that clinical playbook close.